Any other questions or comments from members? Okay, thank you, Ms. Cantwell.
Sure.
Appreciate your ongoing commitment to this issue and your engagement here and participation today. We'll go to our next panel, MediCAL Program Stakeholders Perspective. Panel 1, we have Ann McLeod, Senior Vice President, Health Policy and Innovation, California Hospital Association. Dr. Ruth Haskins, California Medical Association. Sean South, Associate Director of Policy and Legislation, California Association of Primary Care. And Brianna Pittman, Legislative Director, California Dental Association. Welcome, and thank you all for being here and participating in today's panel. Okay. Ms. McLeod, whenever you're ready.
Great. Thank you so much. Good afternoon, Chair and members of the committee. My name is Ann McLeod, Senior Vice President, Health Policy and Innovation for the California Hospital Association. CHA is the statewide hospital association that represents more than 400 hospitals and health systems, including the rural hospitals, urban hospitals, district hospitals, county hospitals, and health systems, the University of California medical centers, not-for-profit facilities, investor-owned facilities, children's hospitals, safety net providers, academic medical centers, and teaching hospitals. And I speak on behalf of them today. California's Medicaid program, the largest Medicaid program in the nation, now serves over 12 million individuals, resulting in nearly 1 in 3 Californians depending on MediCAL for all of their health care needs. Many of these new MediCAL enrollees are fully funded by the federal government for these first few years of implementation of the ACA. The cost of this expanded coverage is a significant federal expense. Picking up the tab for this includes deep cuts in Medicare payments, including about $28 billion in cuts for California hospitals since the passage of the ACA and over the next 10 years. In addition, the President's current proposal includes an additional $10 billion cut in Medicare over the next 10 years. The Medicare facts are important because California is home to the largest population of seniors in the country. 4.8 million Californians, nearly 13% of the state's population, are age 65 and older. And then due to the aging of the baby boomer generation and gains in life expectancy, California's senior population is projected to more than double to over 10 million people by 2040. And the population aged over 85 is projected to nearly triple to 1.7 million residents in that same time period. So why this is important, I'm building on. Nearly 2/3 of these California seniors have 2 or more chronic conditions, and more than 1/3 of them have 4 or more. So when you take that demographic and you couple it with the growing demand for healthcare services from the newly covered MediCAL enrollees, this aging population, and an increase of chronic disease, you combine that with the inadequate supply of primary care providers in California, it fuels the concerns for ensuring access to health care, not only for MediCAL patients, quite frankly, but for all Californians. A couple of statistics I'd like to share with you since the implementation of the ACA. Hospitals are admitting more than 200,000 additional MediCAL patients a year for inpatient acute care. Likewise, MediCAL outpatient visits in a hospital setting have grown by more than 3.6 million visits in a single year under the coverage expansion. And then further, because of reduced payments to an already scarce primary care network of physicians, MediCAL patients have limited access to basic health care needs. And this has driven an estimated 1 million more MediCAL enrollees to hospital emergency rooms every year for their basic care. This is not the most appropriate place for care. We all have heard that MediCAL is one of the lowest funded Medicaid programs on a per beneficiary basis in the U.S. As a result, California hospitals have a payment shortfall of more than $8 billion a year in treating MediCAL patients. This is particularly alarming considering the number of beneficiaries that are enrolled in the program and are banking on getting the care they need when they need it. Now, over the last decade, the state has abdicated its role in providing adequate funding for the MediCAL program by relying more and more on other sources of non-federal share to capture the federal matching dollars. Some of these sources include the use of intergovernmental transfers, the hospital fee, the MCO tax, the nursing home tax, and requiring public hospitals to certify their public expenditures so that they can receive 50 cents on the dollar of every cost of a MediCAL patient. These supplemental sources of funding, they really have provided some relief to providers serving MediCAL patients, but it's important to remember that these provider-funded sources really only mitigate about 40 to 50% at the most of the total losses incurred, meaning that it leaves billions of dollars in uncompensated care for MediCAL patients. Access barriers are amplified by the low MediCAL rates to providers, including those unrestored provider rate reductions that were enacted during California's economic downturn. Expanding coverage without ensuring access to the appropriate type of care in the appropriate type of setting is a problem that the state really must remedy. And I'm happy to answer any questions.
Thank you. We'll go through all the panelists first and we can ask questions at the end.
Thank you, Chairman Bonta and members of the committee for holding this very important hearing. My name is Dr. Ruth Haskins. I practice obstetrics and gynecology in Folsom, California, and I have a very small but busy practice not far from here. I have served this Sacramento community since 1993, after completing 12 years of active duty service as an Air Force physician. In addition to delivering babies and performing gynecologic surgery, I have been involved my entire professional career in public health education and in health advocacy. I'm currently a member of the Board of Trustees for the California Medical Association, and I'm here to speak as a practicing physician who cares for MediCAL patients. Our state's abysmally low provider reimbursement rates are having a direct impact on children and families throughout California. Hospitals, clinics, dentists, pharmacists, physicians, even healthcare insurers all agree that chronic underfunding of the MediCAL program remains one of the biggest challenges in healthcare. And sadly, evidence for this underfunding is manifested in many ways. Under the old fee-for-service model, where physicians billed the state for each procedure or service provided, it was easier to compare our state's Medicaid rates and demonstrate easily the inadequacy of those payments. For example, for the remaining 2 million people who still receive MediCAL services under that fee-for-service system, our rates here in California are fourth lowest in the country. However, with a shift to the MediCAL managed care, the state has essentially privatized the delivery of MediCAL through capitation rates paid to health plans without ensuring that access to care is maintained. In June, the state auditor released a troubling report outlining a number of problems with MediCAL managed care plan networks and potential barriers for patients to access care in a timely manner. There's no doubt among us physicians that the low rates that are paid to managed care plans, that's what's impacting their ability to retain an adequate network of providers. Doctors' offices simply can't stay open without setting low limits on the number of MediCAL patients that we can serve. Patients who have MediCAL are having severe problems finding doctors who are willing to see them. Reimbursement rates prohibit physicians from being able to accept the numbers that we would like to without risking losing our practices altogether. These patients lacking their preventive health care and early treatment turn up in emergency rooms, as was just stated, in advanced medical crisis, costing the state much more money in the long run. Pregnant MediCAL patients who are unable to get early prenatal care have a measurably higher rate of preterm births and other complications. For every dollar spent on prenatal care, that's about $7 that's saved in neonatal care. This is money that could have been saved by adequately funding MediCAL, maintaining provider networks, and getting these patients established with California physicians. It's difficult for us to recruit new doctors into California. It's difficult for us to keep our new grads practicing in this state when they see the low reimbursement rates that MediCAL provides. This is not a problem that's unique to California. Earlier this summer, the Federal Center for Medicare and Medicaid Services released a set of draft rules that focus on Medicaid managed care plan registration and rate development. We view this as an acknowledgement by the federal government that access problems persist throughout the country, and increasing provider rates needs to be part of the discussion. To that end, we are eternally grateful to the governor for calling this special session to tackle this vexing issue of MediCAL funding. We urge you and your colleagues to make the most of this unique opportunity. The MCO tax is obviously of critical importance to the MediCAL program. This is set to expire next year, and the CMA believes that the revenue generated by this MCO tax, matched at the federal level, is an important funding stream that should be renewed. We fear that failure to renew this tax would mean reverting back to the years of devastating cuts to the MediCAL program that impact millions of Californians. We're hopeful that the legislature will use this opportunity to look for additional revenue sources to strengthen the MediCAL program. CMA is now part of a broad coalition of labor, provider, and public health organizations committed to raising California's tobacco tax. This would have the dual purpose of decreasing smoking rates while raising additional revenue for MediCAL provider rates. We strongly urge this committee and the legislature to look at funding solutions like the tobacco tax as you deliberate how to adequately fund the MediCAL program. In conclusion, I want to thank Chairman Bonta and the members of this committee for their work this year. I can say with great confidence that California physicians want to care for this population. We need a partner in this endeavor. Please help us care for the over 12 million patients that need our MediCAL services. Let's please fully fund MediCAL.
Thank you, Dr. Haskins. Mr. South.
Chair and Member Sean South on behalf of the California Primary Care Association. I first want to thank the chair for his leadership, along with Senator Hernandez and their leadership of finding a comprehensive solution through what was AB 366 and SB 243. We really felt like that got to the problem. It dealt with the money that was owed, that had been cut during the worst years of our state. It continued the provider rate bump for primary care, which is essential to keep those folks as that frontline service. And then it also ensured that rates were adequate for the rest of the provider community. So we saw that as the overall solution. We know that we have a long way to go, but we agree that that is where we need to go. I stand here today not because on behalf of my members, because the vast majority of my members do not benefit from any of those proposals. I'm here because we deal with our 5.6 million patients each year, and our members are constantly telling me they can't find specialists. They can't find folks to provide the next level of care for their patients. And it's difficult because you're talking about a group of folks that got into the healthcare business because nobody else was providing care to those populations, whether they be rural, whether they be urban. There was nothing there at the time. So they started a health center. And they provide a vast majority of behavioral health, dental services, everything that they can under their federal mandate, they do. But we don't have control over what goes on beyond our doors. And specialty care is the biggest problem that is created. And the rates are essentially the problem. It always amazes me in this debate that everything in our society is based on what somebody can get paid for something, and that incentivizes people to do things. And when we talk about MediCAL, we expect doctors to just, out of the largesse or out of the goodness of their heart, to just take the rates and continue to participate in the system. And then when they don't drop out, the state says, well, look, there's plenty of people that will continue to take these low rates so we can continue to keep them low. The reality is that we can't expect doctors, because of the goodness of their heart, to continue to participate in a system that they can't afford to participate in. I mean, we've seen the growth of the ACA. You have more patients now in covered California. You have more patients in MediCAL competing for the limited time that a physician has. And the reality is that you can only see so many patients that you lose money on in any week and keep your practice open. So from our perspective, the rates have to be dealt with, and we really think that's the key problem. We do agree that there are some oversight issues. There was the state auditor's report. We do agree that the state has a role in making sure that the networks are adequate, But we also agree that if you don't give the health plans the dollars that they need in order to create those networks, they'll never be adequate. So just in closing, we stand with the We Care for California Coalition. It's one of the broadest-based coalitions I've ever been involved in. CMA is at the table, the hospitals, SEIU, all the folks that care for these patients and really are concerned about the MediCAL system. We stand together because we know that the system needs an infusion of money. We know that we're also dedicated to figuring out how to do that, whether that's a tobacco tax, whether that's a new MCO tax, whatever it takes to make it happen, because the MediCAL system has to work for these patients. We can't give them a card and tell them you have insurance and not give them the same access that all of us enjoy. It's not appropriate, and it's truly it's almost disrespectful to this population to tell them that they now have this access when it really doesn't exist. So with that, I will end. Thank you.
Thank you, Mr. South. Ms. Pittman.
Good afternoon, Brianna Pittman with the California Dental Association. Thank you, Chair and members, for allowing me to be here and to providing the opportunity to share with you the experience of our member dentists who are serving the DentaCal population. Over the past several months, DentaCal has gotten some much needed attention, and several legislative hearings have shed light on the deficiencies in the program that our members have known about for years. And the lack of investment in the dental system of care in DentaCal has really resulted in a system that's in crisis and is unable to meet the needs of California's most vulnerable population. As outlined in the state auditor's audit last fall of the DentaCal program, more than half of the kids in the program were unable to get even a basic or routine preventive visit annually. And based on some preliminary data that we've seen in 2014 utilization, we think that those numbers are even worse, with only 25% of the children in the program getting any care. And really, this indicates that the access to care crisis is getting worse, and that it's not keeping, access is not keeping pace with the enrollment that's gone up, as has been previously mentioned, substantially. And we really do think that to address the deficiencies in this complicated program, it's not just about rates. Rates are important, but it's not just about rates. We talk about it as a three-legged stool. There are reimbursement rates, there's the provider network engagement, and then there's the administrative burdens of actually providing care in the system. And as we deal with these, one of the things we're really excited about is Dr. Jay Kumar, who's recently come on board as this California's dental director, started this month, is going to be putting together a state oral health plan. So we really look at that as a great opportunity to look at, not just oral health throughout the state, but really in the DentaCal program. And while DentaCal is really a small fraction of the entire MediCal program, oral health has a tremendous impact on beneficiaries' overall health. More children suffer from dental disease in the state than asthma, and more school days are missed because of dental issues than any other reason. It's really impossible for adults without teeth to get a job, and so we really see dental as very key to overall health and economic well-being. And regarding provider rates, which I think is probably the first and most important leg of that stool, the 10% rate cut that was just passed in the budget we think is a really important step. Really appreciate the legislature and the governor for passing that. But we think that it really just undid the injustice of the cut in the first place. We know that California's rates are at the bottom of the barrel nationwide. And a report that came out from DHCS on rates just this past month in July demonstrates that there's much more work that needs to be done. The review showed that there's been a 77% increase in adults in the program and a 44% increase in children, while at the same time the provider network in DentaCal has dropped by 15%. So they're going in opposite directions, and access is only getting worse. And the review also found that in 2014, California's DentaCal rates were, for the 25 most common DentaCal services, were well below those in other large states like New York, Texas, and Florida. And we're only 31% of the national average for commercial insurance. And in the December audit, highlighted that the rates to providers are, for the top 10 kid services, are 35% of the national average. And they sort of highlighted for the first time that rates really are connected to access. So we think that the state needs to take every opportunity to identify and implement program improvements and targeted rate increases that can boost provider participation and increase access to care, especially for preventive services for DentaCal's youngest beneficiaries. And to make these improvements real, we need to first avoid creating a hole in the MediCAL budget with the loss of the MCO tax. And second, we need to invest additional state dollars in the program. On the provider network, the state needs to have accurate information on this provider network and to simplify the enrollment process. It's been documented in prior hearings that the referral list of DentaCal providers is woefully out of date. They need to be able to determine who in the network, which providers are active, who's taking new patients, and how many visits of DentaCal they're taking, to be able to see what is the actual access that's out there, because we really have no idea. We have some idea about how many providers are there, but we really have no idea how many visits are available to the patients that needs to be seen. And enrollment is also an issue. The enrollment and recertification process is a huge barrier that can dissuade provider participation. It currently takes many hours, lengthy paper application, over 40 pages of attachments, and we've heard stories of re-enrollments that have taken several months up to a year. And this is just something that sort of further burdens providers who want to participate in the system and are getting paid very little to do so. And the third leg of the stool is the administrative ease of the system. And right now, what providers have to go through to be reimbursed for the care that they're providing is exceptionally cumbersome and difficult. There's extensive paperwork and documentation that's required by the department. There are rules that just don't exist in the commercial market, which make it difficult for dentists to incorporate DentaCal into their regular practice. And we hear from our members that there's ambiguous criteria and inconsistent treatment authorization that make it difficult to provide care. So in conclusion, we have a system of care that provides services to less than half of the children and the people who are eligible for services. And it's clear that we have a serious problem that needs multiple strategies to address it. We think it'll take program improvements like streamlining the enrollment process and the administrative burdens facing providers. And we also think that there's significant evidence that the low provider rates are part of the access crisis. So we encourage additional revenues to increase rates, and we suggest pursuing targeted prevention services and services to young kids as cost efficient in the long run. So we look forward to working with you on this committee, the full legislature, through the special session and beyond to begin addressing these serious issues. Thank you.